you get it in the gut, it gets into your circulation, it attacks the heart, the kidney, the liver, and the brain. So this is a virus of multi-organ, and we're gonna call it the inflammatory virus. Now, how does this work? If you were to take your hand and make a fist, and you were to point your finger out, that finger that you're pointing out would be what we call the spike protein. And the spike protein binds to a cell either in your lungs or in your gut. And when it binds to that cell, it actually, the cell allows that virus to go inside. Now, what's interesting about this virus, that once the virus opens the door with the spike protein, once it goes into the cell, it actually closes the door and locks the door so other viruses can't get in. Then it reproduces itself to have really a lot of new members. So it wants to replicate itself inside of the cell. Once it's done that, those virus members go throughout the cell, and it takes hostage to many of the valuables of the cell. Once it takes control of the valuables, the virus turns off the sprinkler system inside of the cell that's made to the pathways that are important for putting out various types of inflammatory responses within the cell. So it actually turns off the fire extinguisher, turns off the sprinkler system, and then the virus starts a fire. It actually starts a blaze in the cell, and we have different words for these types of pathways that get started. And so, not being technical, let's just call it a fire. It starts a fire, and then it goes into another area, sees another door, and it sees kerosene, and it throws the kerosene down, and it lights the kerosene. And so now you have a tremendous blaze within the cell. The cell can't respond because the sprinkler system is turned off. So it is limited at what it can do. And what happens is that the cell, the fire that starts spreads to other tissues, surrounding tissues, and other organs through what we call a cytokine storm, a storm of blaze that begins to manifest itself. So this virus, while it's very, very toxic, has ability, toxic in itself, also thrives by manipulating the cell it infected and turning off the normal response of the cell, so that now the cell can't respond. And that's why we're having problems with treatments that we're trying to develop, because the normal response units within the cell are deactivated, and the cell can't mount its attack and fight of the virus. The virus is very dangerous, and I want you to know that until we have a treatment or a vaccine, that we're going to be continue to deal with this virus. I make an analogy of an angry dog. If you have a really angry dog that's bitten people, it bit the postman yesterday, it bit the young girl riding on her bicycle as she rode by the yard, it bit her. And then you have to walk by the dog and walk into the yard, it's going to bite you. The COVID-19 hasn't gone anywhere, regardless of what restrictions will be lifted. The dog is still in the yard, and it's still going to bite you. And so in regards to re-entry and reopening, there's some criteria that we'll have to establish in order for us to return safely to our workplaces and to our places of worship. As far as the treatments go, you can categorize them in two types of therapies. One therapy is to attack the virus. So we have vaccines being developed to attack the virus. The problem is that little spike protein that I talked to you about, almost all of the vaccines are targeted to that spike protein. And that spike protein is like a key in a lock. So usually we have one key for one lock. You know, you have a key for your front door, and that key works. So if you think of the spike protein from the virus as a key, and your body or your cell being the lock, well, that virus can make 5 or 6 different kinds of keys to open that one lock. And so they're making vaccines for the spike protein, which can mutate very important interactions that should render the spike protein inactive, but it doesn't. It's still active because it can change the spike protein and the way it looks. it provides a tremendous problem for developing a vaccine. That falls under the strategy of attacking the virus. There's convalescent plasma. This is plasma that comes from patients who've survived or who've gotten over the COVID-19 infection. This can be given to patients taking their plasma and giving that plasma to patients who are fighting the infection. And convalescent plasma works very well, and patients have been responding to it. The problem is that probably for every hospital, you probably can only have about 3 patients to get this life-saving plasma. And so it's not a therapy that will be used for the masses, but it's a therapy that we're now seeing to be very effective. Then there are antivirals. Antivirals are used to inhibit the growth or the replication of the virus. And so these antivirals, Remdesivir is the first one that will be approved probably today. Dr. Fauci announced yesterday that the data was somewhat convincing enough to show a positive effect. It's not a cure, and it will not be considered a first-line treatment. Everyone will probably get this, but it's not considered a drug that if you got this virus, that it will mitigate or turn this virus around. It simply has been shown to cut down the number of days or the progression of some patients from a mild disease to a more severe disease. And we'll see in the ICU for the severe patients whether it can keep them from going from a severe case to death. Most of the drugs that we have, we're working on or in testing in people right now are aimed at developing them for killing the virus. There's other strategies as well, and those include developing strategies to improve how the host responds to the virus. So improving how your cell responds to the virus, actually turning the sprinkler system back on. And this is a strategy that utilizes drugs that actually can cause your cells to turn the sprinkler system back on. And there are clinical trials ongoing right now, especially in Italy and here in the United States, to develop this type of strategy. So there are 2 types of strategies: one to kill the virus, the other strategy to boost the host response to the virus. I will tell you, things like UV light does not work on patients, on humans. Do not try that. Disinfectants, ingesting or washing with disinfectants, please do not advocate those therapies either. We are about probably 6 to 8 months away from a vaccine that will be tried. It's currently several vaccines in phase 2 trials. Those are efficacy trials, and the problem, as I told you, this virus is very sneaky, very tricky. We didn't develop a vaccine for the first SARS that we had in 2003. We didn't develop a vaccine for MERS in 2009, and this one will be equally as tough to develop it. No one cares that the vaccine works, and I know that's a shocking statement to say, but in reality, we only care that the vaccine is safe, because if it doesn't work, there's no market. You won't be able to sell it. It'll be just like hydroxychloroquine, which was touted by several to be useful. It was not safe, and so it couldn't go forward. We want therapies that will be safe and effective. And so the question for this vaccine, that as we do a rapid development, will be the safety of this vaccine in regards to treating COVID-19 patients. I will tell you that we'll be facing this virus well into next year, and other pandemics that will come from this COVID virus in the years to come. There was suspected to be strains of the COVID-19 virus Now we've learned from Wuhan that we have 30 strains of this virus now to deal with. And so not all of them will be highly effective and a killer like the one we have, but nonetheless, we will have to deal with them in times to come. And so as we develop the strategies of how we re-enter our churches, how we re-enter our schools, how we re-enter our workplaces, we're going to have to be cognizant of the fact that until we have a vaccine or a treatment, that we will have to practice the only type of safety net that we currently have, and that's social distancing. Things that have been put forth by public health individuals about why we are susceptible, whether it's access to healthcare or having predisposed sicknesses disproportionately to others. But I want to speak to something completely different. And what we now know about this virus is that this virus attacks a pathway in your cell that turns off that sprinkler system. And we as African Americans, and I'm going to use a big word here, please forgive me, here's a big word and it's coming. We have a polymorphism, and the word polymorphism is a word like looking in a case and you want to buy ice cream, and there are 10 types of ice cream in that case. So you can choose between one of the 10 of those ice creams to eat. Well, we have an enzyme that's a part of that sprinkler system that we can have 10 different flavors of it. And African Americans and others, we're not the only ones. The Italians have the same problem. And that's why it was a tremendous surge of infection and death in Italy as well, because they also have susceptibility to this virus because of the polymorphism in a protein called ACE, ACE. And that protein is why most African Americans are very resistant to angiotensin receptor blockers or ARBs. Most people don't put us on losartan, which is Cozar, or telmisartan, those types of blockers, because we don't get a big drop in blood pressure being put on those blockers, because most of us have polymorphism in that system. But nonetheless, having that polymorphism predisposes us to have a low renin state, and having a low renin state is a real issue in this virus. And so people, cultures that have this pathway that's different than others will be highly susceptible to this virus. And African Americans are one of those types of individuals that have historically have low renin levels. And so, we're working on tests, and others are working on tests to develop to see if you actually have a low renin state as a way of determining whether you will be highly susceptible to this disease. We also have a trust issue with the medical world, and rightly so. We have been mistreated in the past, and if I could make any suggestion that getting help early in this disease can be very helpful. Although we don't have many tools at all, but this is a very serious disease that we have to protect ourselves. We have to protect our elderly. Our children can be reservoirs for this. They are asymptomatic in many cases, but they'll be spreading this disease to those who are less fortunate. And so we have to be very careful as we go forward.